As we were discussing at the end of the last PowerPoint, blood pressure and how things move through the capillaries, right? So diffusion is one of the most important means of transfer for oxygen, carbon dioxide, waste, and nutrients. The solubility of substance is what helps determine the path that diffusion will occur towards, the location it's going to go. If it is lipid soluble, then the substance can go through the cell membrane. This is going to be things like oxygen, carbon dioxide, and fatty acids. Remember that like dissolves like. So if it is a lipid and it is lipid soluble, okay, so lipids are generally going to be lipid soluble. Liquid insoluble substance will have to go through membrane channels. So they're going to need some extra help here. Things like water, sodium, and chlorine. Plasma proteins are going to stay in the blood because they are not soluble in lipids and they're too large to go through channels. Blood pressure is what moves blood through arteries and arterioles. It is the force that the blood is exerting over inner walls. Pressure is force over area. So area would be the diameter and length of the walls. So it moves blood through arteries and arterioles. Blood pressure is going to decrease with distance from the heart because of friction between blood and vessel walls, which we call peripheral resistance. Blood pressure is greater in arteries, and then it's going to decrease as you go from arteries to arterioles to capillaries because they're getting smaller. So flow is always going to go from high to low, right? Flow will be from high pressure to low pressure. So the walls of arteries and arterioles are too thick to allow many of the different components of blood to go through, passage through the membrane. So remember, hydrostatic pressure created by blood is going to push, hydrostatic meaning water pressure basically, but so is a fluid, I should say, not water, pushes small molecules through the capillary walls through filtration. The presence of a solute on one side of the membrane that can't pass will create an osmotic pressure that's going to draw waters into the into the capillaries. We call that osmotic pressure. And this helps to favor reabsorption of different solutes. So solutes and plasma proteins create that colloid osmotic pressure. So we can have several different blood vessel disorders, and we're going to look at just a couple of these. We can have a mitral valve prolapse or even an aortic valve prolapse. So in a mitral valve, if it bulges into the left atrium during ventricular contraction, it can cause regurgitation. So that would be a mitral valve prolapse. In the arterial disease atherosclerosis, plaque is formed and accumulates on the inferior walls of arteries. Blood flow is then going through affected arteries is going to then slow and cause an increase of risk of a thrombus or an embolism. If the wall of the artery is weak, an aneurysm may actually occur or form. Sudden cardiac arrest can result from an artery that is blocked with plaque. Scar tissue from a previous heart attack, and it can also cause an accelerated heart rate. Factors that increase the risk of atherosclerosis are tobacco use, lack of exercise, and a diet high in unsaturated fats. You may have heard of angina before, angina pectoris. This is chest pain or discomfort when your heart muscle is not getting enough oxygen. This is often a symptom of underlying heart disease and is sometimes due to things like ischemia, narrowing or blocking of a coronary artery. The pain of angina pectoris comes from a block in the artery that supplies the heart, so it can be painful. Phlebitis is an inflammation of the veins. This is pretty common, and this can occur due to infection, injury, or just sometimes an unknown cause. Blood flow to the right side of the heart muscle can decrease due to constriction of the right coronary artery and decreased blood flow to the heart results, and we call that ischemia. Our arterial blood pressure is going to rise and fall along with the cardiac cycle. Ventricles contract, which is it systole or diastole? Systole squeeze, so they contract. And so they contract, so blood in the chambers is forced through into the pulmonary trunk and aorta, increasing the pressure in these arteries. All right. The maximum pressure obtained during ventricular contraction is where we get our systolic pressure, and the minimum when the ventricles relax is the diastolic pressure. When arterial pressure drops, the lowest pressure in the arteries before the ventricular contraction is the diastolic pressure. So when you get a blood pressure reading, what you're going to have is systolic is what is on the top and diastolic is on the bottom. So that would be like ideally 120/80. This is a really good practical application, something that almost every single one of you are going to be doing. Taking a pulse. So the expanding and recoiling of arterial walls can be felt, and we feel this as a pulse in an artery that is close to the body surface. We have the radial artery, which is a very common place to take a pulse. It's going to be near the surface of the wrist, and we call that the person's radial pulse. So we use that to feel a radial pulse. There are lots of other different sites though where an arterial pulse is easily detected, okay? And you can see we've got temporal, the carotid. The carotid is pretty well known, but you wouldn't think about the temporal, but if you've been around small children and infants, you can often see there's beating in their head. Facial artery, brachial artery, popliteal, femoral. Femoral is a really good one as well. Posterior and dorsalis, posterior tibial and the dorsalis pedis. And there are applications or times when you would want to feel a pulse radial and then also feel the dorsalis pedis. That can be used diagnostically if they're different. Arterial pressure is dependent upon several different factors, things like cardiac output, blood volume, peripheral resistance, and things even like blood viscosity. So a ventricular contraction is going to determine the volume of blood that enters the arterial system. We call this the stroke volume. The average is about 70 milliliters. The volume that leaves the ventricle in per minute is called cardiac output. And we find this by multiplying stroke volume times heart rate. So if we, for instance, had a stroke volume of 70 milliliters, and 72 beats per minute for your heart rate, your cardiac output then would be 5,040, and that's milliliters per minute. All right, milliliters per minute. So it's just a basic multiplication there. But you want to make sure your units are correct. Milliliters and milliliters are equal to cubic centimeters, remember cc's. Blood pressure is going to vary with cardiac output. If stroke volume or heart rate increase, so will cardiac output and vice versa. All right, so that's a direct relationship. Blood volume is equal to all of the formed elements plus the plasma volume. This can vary, of course, with age, size, and whether you're male or female, but it's about 5 liters or 8% on average of the body weight in kilograms. It is blood pressure is directly proportional to the volume of blood. This is important. Any change, of course, can cause a change in blood pressure. So if you're hemorrhaging, your blood pressure is going to drop because the blood volume has dropped, right? And so fluid replacement can actually help reestablish a normal blood volume and pressure. And so we can give IV fluids to increase that. If we don't have blood, it can still help. Peripheral resistance we talked about, but we'll go ahead and define that. That's the friction between the blood and the walls of the blood vessels, and that's how much they're going to slow things down, how much they resist the flow. So as I said, cardiac output depends on stroke volume and heart rate. Stroke volume is the amount of blood pumped in a single beat, and that's reflected by the difference between the end diastolic volume, EDV, of blood at the end of ventricular diastole in ventricles, and then the end systolic volume, which is ESV, which is the volume after each ventricular systole. So it's the difference between these two. Maintenance of blood pressure then requires these two factors to be regulated. All All right, so let's look at a response to hypertension. Hyper meaning above. So high blood pressure. Baroreceptors in the walls of the aortic arch and carotid sinuses are going to be the ones that detect or sense changes in blood pressure. Those impulses then travel to the receptors in the cardiac center of the medulla oblongata. Parasympathetic impulses then are sent to the SA node, heart rate, and they decrease and return it back to normal. All right, so this is a negative response feedback. Cardioaccelerator reflex will send sympathetic impulses to the SA node in order to increase heart rate. Blood pressure is going to decrease as blood moves through the arterial system and into the capillary network. Those are getting smaller and smaller, and so very little pressure remains at the venular ends of the capillaries. So there are some other factors that help blood flow along. Skeletal muscles, contractions, massage the vessels and help move blood flow towards the heart. Breathing causes the diaphragm to press down on the abdomen, increasing the pressure, squeezing blood out of abdominal veins and into thoracic veins. During exercise, our respiratory movements and muscle contractions work together to move venous blood to the heart. Venoconstriction can also return venous blood to the heart. If pressure is slow, sympathetic reflexes cause smooth muscle contractions in order to speed that up. All right, all veins, except for those that return to the heart from the lungs, drain into the right atrium. This is why pressure there is called the central venous pressure. This pressure affects the peripheral veins. If a heartbeat is weak, the central venous pressure and venous network increase. The heartbeat, if it's forceful, the central venous pressure and network pressure will decrease. An increase in central venous pressure can cause things like edema, peripheral edema in the vascular system and limbs. And so what you see here to the right is what we call pitting edema. And now if you press on yourself, you'll see a little tiny, very brief indentation, but this is an indentation that sits for a very long time. Circulation, of course, is vital because it supplies oxygen and nutrients to all of the tissues that we need them to get to and removes the waste. So we really can't survive without good circulation. Tissues don't survive without good circulation. So remember that we have two major pathways for blood vessels. We have the pulmonary circuit, the vessels carrying blood from the heart to the lungs and back. So pulmonary refers to the lungs. And then we have the systemic circuit, which carries blood from the heart to all the other places of the body and back again, including the coronary circulation, which is the circulation of the heart. So for the pulmonary circuit, the blood is going to enter the pulmonary circuit as it leaves the right ventricle through the pulmonary trunk. Trunks are large, wide portions of arteries that give rise to smaller arteries. And so they just get a new name basically as they get thinner. So for example, the celiac trunk gives rise to the left gastric, common hepatic, and splenic arteries. It's going to divide off into those three. Trunk can also divide into the right and left pulmonary arteries, which then penetrate the right and left lungs. In the lungs, they divide into lower branches, 3 on the right and 2 on the left, and then those accompany the bronchi into the lobes of the lungs. These continue to branch down into arterioles, capillary, and then to capillary networks, and then those are associated or working closely with alveoli. Blood reaches the lungs through the branches of the pulmonary arteries and returns via the pulmonary veins. That is important. The pulmonary circuit's arteries and arterioles are low in O2 and high in carbon dioxide. So low in oxygen, high in carbon dioxide. The left ventricle contracts more forcefully than the right ventricle. So arterial pressure in the pulmonary circuit is lower than in the systemic circuit. Finally, venules are going to merge to form small veins, which converge and form the full 4 pulmonary veins, 2 from each lung. And those return blood to the left atrium, closing the pulmonary circuit. So the systemic circuit is composed of vessels that lead from the heart to all the body parts except for the lungs and back to the heart again. And of course it includes the aorta and its branches. A system of veins also that return blood to the right atrium. Oxygenated blood flows from the left atrium to the left ventricle. Contraction of the left ventricle forces the blood into the systemic circuit, aorta, and branches. These carry blood to all the body tissues, and a system of veins returns them to the right atrium. The aorta is actually the largest diameter artery in the body. It extends upward out of the left ventricle, arches over the heart to the left, and descends just anterior to the left of the vertebral column. Many of these we will go over in lab, so I'm not going to point out the exact location of all of these in order to save time on the lecture portion. The aorta arises or attaches to the heart at the aortic root. The aortic sinus is opposite of each of the three cusps. Remember, a sinus is a sac or a cavity in any organ or tissue. So coronary arteries arise from the two sinuses. We have the brachiocephalic artery supplying the upper limb and the head, and then it divides on and becomes the common carotid in the subclavian. If you see like the little A, just A period, that means artery, V period for vein, that type of thing. So when you see those, don't let that confuse you. It's just a way to abbreviate them. Here we have the aortic arch, and I would highly recommend that you draw this drawing here out and memorize it and do it in red so you know that it's oxygenated. We have the aortic arch, which is proximal. You want to know proximal to distal, know your ABCs. All right, so the heart's left ventricle pumps blood through the entire body. After leaving the ventricle, the blood enters the aorta, brachiocephalic trunk, common carotid arteries, ABC. All right, and the left subclavian artery after that, and that's where the S comes from. So you want to know your ABCs. All right, so that's how you can remember these, ABCs. Okay, ABCs. So you want to find these mnemonic devices to help you, but that's really more for lab. So after leaving the left ventricle, blood enters the aorta, brachiocephalic trunk, left common carotid artery, and the left subclavian artery. All right, these structures are what make the aortic arch. There are reference points that help you to know when a vessel changes from one name to another. So be sure that you learn these reference points, all right? So after supplying the left subclavian artery, the aorta descends into the lower body. So we have 6 major arteries branching from the descending aorta. Celiac trunk, superior mesenteric, renal, gonadal, inferior mesenteric, and common iliac. Descending aorta, proximal to distal branches, the way to learn that is canned soup, really good in cans. That's a mnemonic you can use there or make up your own. Okay, so above the diaphragm, the descending aorta is the thoracic aorta. Below, it becomes the abdominal. So learn those differentiations of where they change from one name to another, and draw them out, color code them, and diagram them. It's really going to help you in lab. So the abdominal aorta ends near the brim of the pelvis. It then divides into the right and left common iliac arteries. It supplies part of the abdominal wall, pelvic organs, and lower extremities. I left this in here in lecture because I want to make sure that you see it, because often students miss this in lab. Even though it is on there in lab, students tend to not focus on this, and the circle of Willis is important. So in the cranial cavity, the vertebral arteries come together to form the basilar artery. This passes along the brainstem and divides to supply the pons, midbrain, and cerebellum. And it's going to stop or terminate and divide into 2 posterior cerebral arteries, which supply occipital and temporal lobes. The posterior cerebral arteries then are going to form the cerebral arterial circle, or what is known as the circle of Willis. Well, why would this be important to know? Well, if you have damage to one of these vessels, you know which portion of the brain it is potentially going to be harming. Or if you have symptoms in a portion of a brain, you might be able to know which area you may have a blood vessel hemorrhaging. Here, I just want to point out some landmarks for you. That's the yellow arrow. The subclavian artery is going to branch off to the neck, and when it passes between the clavicle and the first rib. Okay, so you want to look for the first rib. That's when it's going to become the axillary artery, which supplies the axilla, chest wall, skin of the shoulder, mammary glands, shoulder joint, upper and back chest muscles. When it leaves the axilla, which is the second arrow, it becomes the brachial artery. Okay, so when it leaves the axilla there at the second arrow, it becomes the brachial artery, and then it divides off to the deep brachial artery. Once it passes the elbow, so the elbow is the third arrow there, it divides into the ulnar and radial arteries. Ulnar artery is then going to lead down towards the ulnar side of the arm and the wrist. The radial artery is going towards the radial side of the arm to the wrist. All right, so learn those places where they differentiate, because they're just continuing along and they get a different name based on location or when they split. All right, again here I'm just going to point out what's at the arrows here. We've got the abdominal aorta dividing at the pelvic brim. Okay, and that's going to then become the common iliac arteries. All right, those supply pelvic organs, your glutes, and your lower limbs. All right, popliteal literally means behind the knee, so you can see that arrow here, and then you can see there at the anterior tibial artery. That begins at the lower border below the popliteal fossa. So the anterior tibial artery is going to pass between the tibia and the fibula and then continue on to the foot and become the dorsalis pedis. So this is just kind of a summary here. The vessels of the venous system originate with the merging of those capillaries into venules. Venules go to small veins go to larger ones. Okay. These are a little bit more difficult to follow because there are some irregular networks and unnamed tributaries here, but you will have some similarities between your artery and vein names. Pay attention to the ones that are not the same. That's what you want. I would learn your arteries first, then learn your veins. Pay attention to the ones that are different, okay, on the veins. All right, so we have the external jugular that is draining blood from the face, scalp, and neck, descending to the right and left subclavian veins. They're going to go on down and unite to become the brachiocephalic. And here's the point here. They merge at the mediastinum to become the superior vena cava, mediastinum. A few important points here. The deep and superficial veins drain the upper limb. Deep veins are going to often parallel arteries and have similar names. We have the median cubital vein, which is at the bend of the elbow, easily seen, and is the site for venipuncture or blood draw. This is one that is actually missing from the cadaver, so I really wanted to point that out. You can see that here. We've got a lot. All these things that are here in red on the PowerPoint are things that are on our list. And that I wanted you to focus on. All right, veins typically carry blood to the atria of the heart directly, but not the abdominal viscera. So these begin in capillary networks of the stomach, intestines, etc., and carry blood through the hepatic portal system. And then the tributaries to the hepatic portal are things like the right and left gastric from the stomach, superior mesenteric coming from the small intestines, ascending and transverse colon, and then splenic, which of course comes from the spleen, pancreas, and stomach. And then we have the inferior mesenteric, which is descending colon, sigmoid colon, and the rectum. So how does the cardiovascular system typically change throughout our lifespan? Well, the heart normally will shrink with age. If you have heart disease, however, it will usually enlarge it because it is working harder. Heart valves typically begin to thicken and become more rigid after the age of 60. Your heart rate slows with age, and the cardiac cycle lengthens by 2 to 5% about per year. So the heart rate in a fetus is higher. It's about 145 in a newborn, 145 in a fetus, 140 in a newborn, but an adult is usually about 70 beats per minute. Resting heart rate decreases your elasticity decreases, and this contributes to a normal increase of blood pressure as you get older. So while 140 and over 90 is a very high, well, a high blood pressure for someone that is younger, an elderly person, that is not really abnormal to find. So looking at age is an important thing to do.